Multiple sclerosis affects 2.8 million people worldwide. For anesthesia professionals, encountering patients with this demyelinating disease of the central nervous system is a certainty. Historically, clinical dogma dictated that the physiological stress of surgery and the administration of general anesthesia would inherently trigger an MS relapse. Modern clinical data corrects this. Surgery itself is safe for MS patients. The high rates of perioperative morbidity observed in the past were largely iatrogenic, driven by provider mismanagement. This mismanagement typically occurs across three distinct variables: failing to control core temperature, administering specific depolarizing muscle relaxants, and stopping disease-modifying therapies. The February 2026 MS preoperative anesthesia guidelines provide the definitive protocol to neutralize these specific risks. Securing a safe outcome for an MS patient requires abandoning clinical intuition and strictly executing a pathophysiology-based triage model. The mandatory first step of this model is the tripartite risk stratification protocol. Patients filter into the low-risk category if their EDSS is 3.5 or lower, have no relapses in 6 months, and maintained a stable medical regimen for 3 months. When an MS patient meets all of these criteria, the anesthesia provider can safely clear them for surgery without consulting a neurologist. The moderate risk category captures the clinical gray area. This includes patients with an EDSS between 4.0 and 6.0, mild autonomic dysfunction, or a recent relapse that has stabilized. Proceeding with surgery for a moderate risk patient requires at minimum a records review or a telephone consultation with their treating neurologist. Absolute clinical triggers push a patient into the high-risk category. Active relapses, an EDSS greater than 6.0, and severe bulbar dysfunction like dysphagia demand mandatory formal clearance. Specific respiratory metrics also force a high-risk classification: a vital capacity below 70% of predicted, or a maximum expiratory pressure under 60 centimeters of water signals severe respiratory muscle weakness. Applying this objective scoring matrix removes guesswork. It prevents practitioners from clearing patients whose baseline neurological or respiratory reserves cannot withstand the stress of surgery. The standard surgical instinct is often to halt immunosuppressants prior to an operation to minimize the risk of postoperative infection. In multiple sclerosis, applying this instinct is dangerous. The risk of disease reactivation and severe neurological rebound far outweighs the potential surgical infection risk. Consider S1P receptor modulators like fingolimod. These agents actively sequester lymphocytes within lymph nodes. Abruptly discontinuing them releases these trapped cells, triggering a rapid migration back into the central nervous system, causing a severe rebound attack. S1P modulators also carry a specific anesthetic implication. They cause baseline bradycardia. This necessitates a preoperative ECG and strict avoidance of interacting drugs like beta blockers or calcium channel blockers. For patients on anti-CD20 therapies or natalizumab, the protocol is to continue therapy, ideally timing elective surgeries mid-cycle to balance continued efficacy with standard infection precautions. In contrast, high-efficacy therapies like alemtuzumab or cladribine cause profound, long-lasting lymphocyte depletion. Elective surgeries must be avoided entirely during treatment weeks and for up to 6 months post-infusion. An MS patient's physiological stability is tethered directly to their DMT regimen. Making a unilateral decision to stop these drugs invites a neurological crisis far worse than standard surgical complications. Once in the operating room, airway pharmacology presents the next major clinical trap. The depolarizing muscle relaxant, succinylcholine, is completely contraindicated in MS patients presenting with motor weakness, spastic paraplegia, or immobility. Demyelination causes the body to upregulate extrajunctional acetylcholine receptors. Abnormal channels rapidly multiply along the muscle membrane. When succinylcholine binds to this expanded population, it triggers a massive, uncontrolled. This sudden, profound hyperkalemia frequently leads directly to life-threatening cardiac arrest. The clinical solution is straightforward. Utilize non-depolarizing agents like rocuronium. However, due to increased sensitivity, initial dosing must be reduced, and quantitative train of 4 monitoring is mandatory to ensure safe extubation. Multiple sclerosis alters receptor biology at a microscopic level. Applying standard airway pharmacology without accounting for this specific pathology directly threatens the patient's life. The most easily overlooked intraoperative variable is the patient's core body temperature. Patients with MS are subject to Uthoff's phenomenon, where even a minuscule increase in heat severely exacerbates neurological deficits. This line graph plots core body temperature against nerve conduction speed. A temperature rise of exactly 0.5 degrees Celsius is enough to trigger a complete action potential conduction block in demyelinated fibers. Preventing this requires strict countermeasures. The operating room must be maintained between 18 and 21 degrees Celsius, and continuous core temperature monitoring is mandatory. Similarly, historical anesthesia dogma held that regional and neuraxial techniques, like spinals and epidurals, provoked MS relapses. Recent clinical data dismisses this fear. Modern spinal and epidural techniques are safe, provided specific pharmacokinetic precautions are taken. The strict caveat for neuroaxial anesthesia is dose minimization. Providers must use the absolute lowest effective concentration and volume of local anesthetics, such as 0.25% bupivacaine or less. Demyelinated neurons are hypersusceptible to local anesthetic neurotoxicity and heat. The anesthesia provider must aggressively micromanage the patient's pharmacological environment to prevent a pseudo-relapse. In the postoperative PACU or ICU, high-risk patients, particularly those with an EDSS over 6.0 or active bulbar symptoms, require extended, continuous monitoring. Baseline immobility from MS compounds standard surgical risks, necessitating aggressive venous thromboembolism prophylaxis and rigorous pulmonary toilet. The mandates are clear. Stratify clearance by objective risk. Never blindly discontinue a DMT. Avoid succinylcholine entirely and maintain strict normothermia. By treating multiple sclerosis as a condition requiring precise physiological optimization rather than fearing it as a surgical contraindication, clinicians ensure safe, predictable outcomes.